mood and affect.
EXEMPLAR, schizophrenia and bipolar.
Emotions, mood and affect are critical elements of the human experience in that they shape and reflect our perceptions of and interactions with the world around us. Emotions, an individual's feeling responses to a wide variety of stimuli. It is reactionary and linked to a specific event or object that can be identified by the person. Mood, an enduring state of mind rather than a discrete reaction, it can shape a person's general expectations about the future. Moods do not produce observable physiological reactions, affect an individual's automatic reaction to an event or situation. The immediate, observable expression of mood.
Akathisia, catatonia, anhedonia.
Delusions,
Echolalia.
extrapyramidal side effects, hallucinations,
Pseudo-Parkinsonism.
psychosis,
Tardive dyskinesia.
word salad. Economic and social factors, such as rapid changes, stressful work conditions, and isolation. Unhealthy lifestyle choices, such as sedentary lifestyle or substance abuse. Exposure to violence, such as being a victim of child abuse. Personality factors, spiritual factors, cultural factors, changes or impairments in the structure and function of the neurologic system. For example, cerebral abnormalities often disturb a client's intellectual ability, communication ability, or emotional behaviors. Psychosocial developmental level and issues. Genetics, neurochemical. History. Determined the patient's mental ability. Complete health history. I.ESS for altered thought process. Past medical treatment for mental health. Past counseling services. Family history of mental disorders, ability to carry out ADLs, substance abuse, current stressors in life, suicidal ideation, suicidal attempts, examination, inconsistent orientation, concentration, posture, level of anxiety, level of appropriateness, level behaviors, inappropriately dressed, i.e. cold weather clothes worn in summer, abnormal speech, observe thought processes, identify suicidal tendencies, interrelated concepts, self, cultural diversity, development, nutrition, safety, communication. A complex brain disorder that affects thinking, language, emotions, social behaviors, and the ability to perceive reality correctly. Schizophrenia is thought of as a syndrome or as disease process with many different varieties and symptoms. DSM-5 criteria, exact cause is unknown, may result from a combination of genetic, biological, cultural, and psychological factors. Many individuals with schizophrenia live successfully in the community. Diagnosed in late adolescence or early adulthood, peak incidence of onset is 15 to 25 years of age for men and 25 to 35 years of age for women. Schizoaffective disorder is diagnosed when the client is severely ill and has a mixture of psychotic and mood symptoms. Delusions, hallucinations, psychosis, depersonalization, irrealization, grossly disorganized thinking, speech and behavior, flight of ideas,
Echolalia, catatonic.
clang association, word salad,
Ambivalence.
perseveration, flat blunted affect, volition, social withdrawal or discomfort,
Anhedonia.
apathy, catatonia, mutism, waxy flexibility, inattention. Paranoid, Strong irrational suspicion with dominant symptoms of hallucinations and delusions. If a client sees a nurse talking with a psychiatrist, the client may believe the discussion is about them. Disorganized. The most socially impaired form, with dominant symptoms of disorganized speech and behavior, as well as inappropriate affect.
Bizarre mannerisms, poor hygiene, constant muttering to oneself, often found in homeless population.
Catatonic. The essential features abnormal levels of motor behavior, either extreme motor agitation or retardation, withdrawn, mute, refuse to participate in activities versus hyperactive behavior, talk, shout continually. First-generation/conventional antipsychotics. Chlorpromazine, thorazine, thiaritazine, Melaril, flufenazine, proloxin.
Haloperidol, Haldol.
Second-generation/atypical antipsychotics.
Olanzapine, Zyprexa, Risperidone, Risperdal, Twichapene, Seroquel.
Aripiprazole, Abilify. What are some nursing interventions to know? What client education needs to occur for these groups of medications? Assess suicide and safety risks. Provide safe, secure milieu environment, structured environment. Establish a trusting relationship. Avoid direct questions. Client may feel threatened. Maintain therapeutic, objective, clear, concise communication. Calm tone. Address client by name. Observe for early assess of escalating behavior. Tolerate silences. Clients may be too anxious to speak. Reduce stimulation. Provide solitary activities until patient able to participate in group activities. Provide simple activities, or activities that promote positive self-esteem. Finger painting, clay, art therapy. Avoid competitive activities. You are working on an inpatient psychiatric unit and are to do an initial assessment on RB, who has just been admitted. He has a diagnosis of schizophrenia. He is 22 years old and has been attending the local university and living at home with his parents. He has always been a good student and has been active socially. Last semester, his grades began declining, and he became very withdrawn. He spends most of his time alone in his room. His grooming has deteriorated. He can go days without bathing. For several weeks before admission, he insisted on keeping all of the blinds and curtains in the house closed. For the past 2 days, he has refused to eat, saying, "They have contaminated the food." As you approach RB, you note that he appears to be carrying on a conversation with someone, but there is no one there. When you talk to him, he looks around and answers in a whisper but gives you little information. He states, "They are watching me and told me not to cooperate." Bipolar I, mood disorder characterized by at least 1 week-long manic episode. Manic episode may alternate with depression. Bipolar II, low-level mania alternates with profound depression. Risk factors. Neurochemical risk factors, serotonin and norepinephrine, hormonal fluctuations, genetics, family HX, psychosocial stressors. More common in highly educated individuals. First manic episode generally occurs between teenage 30 years. Young men early in the course of illness equals highest risk for suicide. Begin suddenly, escalation of symptoms over a course of few days, lasting weeks. Euphoria, heightened, grandiose mood, attention-seeking behavior, agitation, exaggerated self-esteem, sleeplessness, pressured speech, increased talking, flight of ideas, high-risk activities, poor judgment, impulsivity, increased energy, possible presence of hallucinations or delusions. Gradual slide into depressive state, may last weeks to months. Flat, blunted affect, tearfulness, crying,
Energia, anhedonia.
difficulty concentrating, focusing, self-destructive behavior, decreased appetite, disturbed sleep, psychomotor agitation, retardation. Lithium, therapeutic level 0.61.2 MEQL, becomes toxic greater than 1.2 MEQ. Toxicity. NV, abdominal pain, lethargy, confusion, muscles weakness, tremors,
ataxia,
increased UO, convulsions, diet considerations, daily weights, strict INO, anticonvulsants, carbamazepine, Tegretol. Therapeutic level is
负12 mcgml,
bone marrow suppression, valproic acid, Depakote. Therapeutic level is 50-120 mcg/ml. Photosensitivity, hepatotoxicity, bone marrow suppression, antipsychotics, SSRI, antidepressant, fluoxetine, Prozac. Monitored for serotonin syndrome. Electroconvulsive therapy, ECT. Provide for patient safety and also those around. Assess suicidal tendencies. Limit setting, if applicable. Decrease stimulation. Calm milieu. Seclusion. Monitor for escalating behavior. Calm. Matter-of-fact communication style. Consistency of staff members. I.E. Same nurses assigned equals familiarity. Promote rest sleep. Diet. Finger foods. High-calorie protein. Encourage nutrition eating. Please review the PP slides in e-learning. A 21-year-old client was recently diagnosed with schizophrenia. He has been taking chlorpromazine, a first-generation antipsychotic, for several weeks. Today, his mother found him having a seizure and she called 911. In the ED, the nurse documents the following VS and assessment.
temperature 104 F HR 118 BPM
RR 26 breaths min.
BP 174 102 mmHg Oxygen set 91
310-inch abdominal pain. Muscle rigidity in all four extremities. Drowsy. Nausea without vomiting. A 21-year-old client was recently diagnosed with schizophrenia. He was taking chlorpromazine, but it has been discontinued due to recent major complications. He has now been started on haloperidol. 2 weeks later, he tells his mother that he is having difficulty holding down a job and has asked to move in with her while he gets his life together. 6 weeks after starting haloperidol, he begins to experience constipation, resting tremors, urinary hesitancy, blurred vision, facial muscle spasms, muscle rigidity, very dry mouth, and dizziness when changing positions. The client developed several EPS from taking chlorpromazine and haloperidol. Today, his provider has discontinued them and started olanzapine 10 mg PO daily. The client is concerned that he will experience EPS again.
Schizophrenia.
Positive versus negative symptoms, nursing interventions, medications.
Bipolar.
I versus 2, mania characteristics, nursing interventions, medications.